on this computer, then live on Facebook. It's been happening every time, or it doesn't let me connect to Facebook. I'm gonna have to do it again. Sorry for those people that are watching the recorded version. It's gonna take a little bit longer until I can open this back up.
Can you guys hear me now?
Yeah,
There you are.
I've been here the whole time, but you know that anyway. Computer, one plug doesn't. You plug something in, it doesn't work. Something you unplug it, it works fine.
Yes, I get it.
how are you doing?
Oh, I'm doing great. What you didn't hear me say is I'm a big fan of osteopaths. So, so congratulations on getting one on your program. It's going to be it's going to be fantastic. I love it.
We're so excited to have Annette here with us. So excited.
That is
yeah,
awesome. I am actually hey, Dr. Rose, how are you? I'm actually trying to open back Zoom and it's not letting me. Oh, let's see if I click on the bottom. Okay, it happened. Well, thank y'all for being here. So cool. AAPMD, is everybody here going to the AAPMD? We are going to have fun. Y'all better be there.
Dee's going to be there. I saw her raise her hand.
Yay. Page, go live. There we are. Welcome everybody. It is Thursday night and we are here with Annette Holtz. We're going to be talking today about osteopathy and health. I am going to let Angela introduce our guest, and then she's going to say hello to you guys, and she has a wonderful presentation to share with us all. So here we go.
Thank you, Renata. Annette Holtz, DO, is an osteopath in private practice in Los Altos, California, where she treats patients with chronic pain, TMJ dysfunction, and craniofacial disorders. For many years, Dr. Holtz has worked directly with Dr. Derek Nordstrom, inventor of the ALF. She also regularly co-treats with several ALF providers and other dentists around the Bay Area and coordinates the Bay Area ALF study group. She has treated several hundred ALF patients in addition to patients with a number of other dental appliances. Dr. Holtz is the immediate past president of the Osteopathic Cranial Academy, a member of the OCA Board of Directors, and serves on the teaching faculty for the OCA. Dr. Holtz is a graduate of the Massachusetts Institute of Technology, Stanford University, and Touro University College of Osteopathic Medicine. She completed an internal medicine internship at Alameda County Medical Center in Oakland, California. Thank you so much for being here with us tonight. We are thrilled to have you.
Okay, thank you. Well, thank you for having me. I am going to, let's see, I think I have to share my screen.
Correct.
And then.
There we go. You are up and running. I see your screen.
There we go.
Perfect.
Okay, so I didn't really know exactly what you guys wanted, so I'm going to have sort of a high-level high-level discussion of osteopathy and how it fits in considerations with dental patients. And then I'm going to talk a little tiny bit about ALF because it's something I work with a lot, but I'm not the dentist, so I'm not the expert. And I'm happy to answer questions and take this any direction if there's other things that you want to know or you want me to go in more depth in. So we've got my background. So what is osteopathy? That's the first question. And it's a good question because there's not a simple answer. We start with, I am a DO, which means I'm a doctor of osteopathic medicine. Approximately 8.5% of the practicing physicians in the US are DOs. DO and MD are the two degrees that allow you to become a physician in the US. But 26% of the medical students in the US are DOs. And so that number will be growing. And in fact, you've probably been treated by a DO, or there's a good chance anyway, in the course of your interfacing with medicine without maybe even knowing it. So DO versus MD is, 95% of the education is the same, but there are a few differences. And I want to highlight some things that matter for this conversation. So there's the unique osteopathic philosophy, and I'm going to talk about that in a minute. About 50% of DOs go into primary care versus US MD graduates, it's about 10%. And then all DOs, so like all DOs study what we call osteopathic manipulative medicine in medical school. All DOs and MDs both, we all study obstetrics and psychiatry and surgery and all the basics of medicine. But in addition, DOs study OMM, all of them. Now that combined with that 50% in primary care means that some primary care DOs will do osteopathic manipulation in the context of their primary care practice. But MDs can also study osteopathic manipulation. They don't do it until after they graduate from medical school. So it's not very many of them, but some of them do. Which means if you specialize in osteopathic manipulation, as I do, that's usually what we call an osteopath. But as I showed here, is an osteopath can be an MD as well as a DO. And this is why it's a little confusing to answer that question. So I'm an osteopath. I specialize in osteopathic manipulative medicine. It's all I do. I treat and diagnose with my hands neuromusculoskeletal disorders. And because I work with dentists, a lot of those neuromusculoskeletal things that I treat are craniofacially related. All right, so I talked about the unique osteopathic philosophy. And I want to go over it very briefly here because and highlight a couple things that might be interesting or important for you guys. So the first principle in osteopathic medicine is that the body is a whole. It's a unified single organism. And that includes, it's a unit of mind, body, and spirit, but it goes beyond that. It's, in a structural sense, it's one thing. The head is connected directly to the feet. The internal workings are also all connected. You cannot take out the cardiovascular system or the nervous system or the endocrine system and consider it just on its own because it's affected by and affects all other parts of the body. And so that unification and looking at the whole person, and you'll hear this a lot about DOs, is they're more holistic. And that's really what this means, is that this basic principle that we look as the whole, not as a collection of 22 different specialty parts. And I sometimes use the analogy of the blind man describing an elephant, sorry. And my job as an osteopath and as a DO is to not worry about so much about the specifics of each little piece, but to take the global view of that whole elephant, which is often the sum total of the little pieces that go together. And that's true not just in the dental context, but in all of medicine. All right, so the second osteopathic principle is that the body is capable of self-regulation, self-healing, and health maintenance. The body heals itself. We do not heal people. We do not fix people. They heal themselves. If this were not true, we would never do surgery. Right? So now sometimes the body needs some help in that. And that's where we come in. You guys, the dentist, the myofunctional therapist, me, is providing the help for that body to get up over a hump to heal itself. There's a fair number of times in a relatively healthy person where I won't say that what help they get doesn't matter, but there are many different kinds of help which will help comes with the people who don't have as much resilience, who don't have as much innate health, and the help that they need becomes much more specific or individualized. Now my slide won't advance. There we go. The third principle, and a third basic osteopathic principle, is that structure and function are reciprocally interrelated. And this is the key to why we do osteopathic manipulation, is that by affecting the structure, by treating the structure, we can improve the function. And I say they're reciprocally interrelated, but really of the two, function is more important. Function comes first. It comes first even embryologically. The function starts and the structure grows around the function as the embryo develops. It's also true in a grown human being. I see lots of people who have far from perfect structures, but they can be very healthy if their function is good. The opposite is not true. You can have perfect structure, but if the function doesn't work, that person is not healthy. And so I give that primacy to that function, to that piece of the structure and function. And then the last osteopathic principle is that rational treatment will incorporate the above three principles. And this is the other piece of where this concept of holistic treatment comes in, that we keep these in mind, whatever we do, whatever drugs we use, whatever surgeries we do, whatever interventions, that we keep in mind that we're looking at the whole person, we're helping the body, but we're not fixing it, it's going to heal itself, and this relationship between structure and function. So I'm an osteopath, but more specifically, I'm a cranial osteopath. I do osteopathy in the cranial field. Now, most DOs who do osteopathy and MDs do work in the cranial work. It is a little bit of an advanced study, but the vast majority of us have learned it, and it's important particularly in private practice. Where it's less common is in the people who are doing osteopathy as primary care doctors, because it's not their full-time job. They don't always have this kind of training. So I'm going to go over a few principles of osteopathy in the cranial field, because again, they're important and I want to make some points about them. So the 5 phenomena of cranial osteopathy is, the first one is the articular mobility of the cranial bones. Now the cranium, many people will say the skull is fused. It's not, and I know it's not because I can do that with it. The skull is made up of 22 different bones. They all move a little bit. They don't move a lot. There's not gross motion in them, but they all move a little bit. And they have to move in a well-functioning system. When they don't move the way that they're supposed to is where we run into problems. And if you look at this picture, you can see that these articulations between the different bones in the skull and the face, and in the skull and in particularly in the face, are very intricate. They're complicated interactions of how these bones move together and move against each other. And they're reproducible from one skull to another. These complicated interactions and these complicated articulations are the same from person to person to person. So that it's clear that they interact in a way that provides function. And we teach a whole 40-hour class on this, so I'm not going to go into a lot of detail, but I just want to point out this phenomena, because it comes up a lot when we're working and putting forces into this system. There's a lot of places where you can muck things up and be completely unaware of it. The second of the 5 phenomena is the fluctuation of the cerebral spinal fluid. So inside that cranium, this bony structure, is the brain. The brain is surrounded by meninges or dura, and that dura keeps cerebrospinal fluid around the brain. The cerebrospinal fluid is very important. It's what provides nutrition to the neurons. You've heard of the blood-brain barrier. There's a barrier. The body or the brain uses 25% of the glucose, the energy of the body. It has to get there across the blood-brain barrier. And the way it does it is in the CSF. The choroid plexus takes it out of the plasma in the in the blood vessels of the brain, puts it into the CSF, and then that CSF has to be circulated around to all parts of the brain. And so this is something that was actually just seen on MRI a couple of years ago, although it's been described in the osteopathic literature for 80 or 90 years. But we now have seen that this fluctuation is important with the mobility, because they interact with each other. As the fluid moves, the bones move. As the bones move or don't move, they interact with the flow of the fluid. Now, it makes sense that if you have this cerebrospinal fluid that's the key to neuronal energy supply, it's probably not a passive diffusion system. There's a way that the body gets it around. And so the central nervous system, the brain, actually moves. We don't know completely how. We know some of the pieces. Again, it's been seen now on fMRI, various and assorted of the pieces. We don't know the whole thing, but it almost has to be true. As I said, that it's so key to the functioning of everything in the nervous system. So you have the brain moves. moves the fluid around. And then the dura, the meninges, also move. They're attached to the bones of the head. They contain the cerebrospinal fluid. And so, of course, they're going to move in this whole system. And I just want to highlight that all of these things can be affected when we start to put forces into the mouth and the oropharynx and the face. So all of these things that can be affected. And then the last one in the phenomena of cranial osteopathy is it's not just the brain, it's the central nervous system, which includes the spinal cord. And so that dura, meninges cover the spinal cord, go all the way down to the sacrum. There's an attachment at C2, the upper cervicals, and the next hard attachment is on the sacrum. And so there's a direct link from the sacrum to the cranium. And so we have the movement of the sacrum through that dural connection. So as I said, so the first takeaway is there's a lot of things that when you're working in the oropharynx, you can inadvertently affect. And so and just for everybody to start to be aware of that. And then you can educate yourself and learn how to understand better, what am I mucking with what things am I going to do, etc. But the first one is just to know that. So I have a couple of examples. Now, these are extreme examples, I will admit, but they're not unique. So case study number one, this is Ruth. Ruth, when she was 14, got a Herbst appliance. A month after she got her Herbst, she stopped having a period. For the next 6 years, she had what we call secondary amenorrhea. She did not have a period. Now, her doctor put her on oral contraceptives, and she had a period for a few months, but the oral contraceptives made her so horribly depressed, she couldn't tolerate being on them, came off. When she hit 20, she graduated from a pediatric doctor to an internal medicine doctor, ended up with a friend of mine as her internal medicine doctor, and who sent her to me. Ruth had two issues. The first one was that Herbst locked things up, but it was on a system that was already compromised. And in her case, the compromise was the sacrum. She had fallen down the stairs, butt first, boom, 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 all the way down the stairs when she was 5, and she had completely locked the sacral end of that system that I just described. Now, why did she lose her period? That's not the first thing you think of when you think of secondary amenorrhea. But what we know is, and this goes back to the whole person, that the pituitary sits in the cellulose of the sphenoid bone. And that sphenoid, as I said, it moves. It actually flexes and extends, it rocks. And that helps pump that pituitary. So on this already compromised system, the Herbst yanked her face forward and it locked that up. And she probably had some other compromises going on there too. Now, I've seen this in other people, not quite to this extent, but I've had 3 other patients, adult women, who had dysfunctional periods of some sort or another, menstrual dysfunction, that resolved after several months in an osteopathy. I was also in a dental study group that where the dentists were training, and there were 6 dentists. They were each doing 2 cases in kids, various and assorted ages, sort of 5 to 14, I think. And they presented their patients to the group with a lot of things. And then 3 months later, we came back and they had all delivered their ALFs and they made an update presentation. And what I noticed, because one of the things they were doing is putting them on, mostly they were looking at posture, but they were all putting on growth charts. Every single one of those kids in that 3 months had gone through a 1 to 2 inch growth spurt. The kids go through growth spurts, but these were all different ages and they had all done it in that 3 months after the ALF went in. And I think it's the same thing, just a little bit of stimulant on that pituitary, of course, being also the source of growth hormone. So it's not unique to this case, although this one's more extreme. Case number 2, I don't have a picture of her. This is a little girl who got braces when she was about 8 years old and very quickly developed severe social anxiety, widespread chronic pain, Tourette's, she had tics, and obsessive compulsive disorder, such that she wanted everything done in powers of 2. 2, 4, 8, 16. I saw her one time after her brother, who was being a pill because that's what brothers do, said goodnight to her 3 times and then went in his room and locked his door. And she had a complete meltdown. She was so OCD. So this was, again, probably a compromised system beforehand. I didn't see her beforehand. And I didn't have anything to guess. So I guess there was some compromise there already, but all of this severe psychological impact. She had to be pulled out of school. She was homeschooled for a year. And then when the year she went back to, or the semester she went back to school, I made an agreement with her mother that I would treat her every single week, to the extent of a couple of weeks I was on vacation and I would come home on Sunday night and see her, because that's what got her through the week. At this point in time, she's now 14. I saw her a couple of weeks ago because she fell and sprained her ankle at camp, but the last time I had seen her before that was about 8 months. So she's very functional now, but had really got put through this severe impacts from her braces. And the last case is this is Romy. She, in her junior year of high school, she got braces. She started having a lot of social anxiety, a lot of depression. She was in therapy. They were just debating antidepressants. She said on her mood on a scale of 1 to 10 was 2, maybe 3, 4 on a really good day. Now, in this case, there was not compromise in the system. And I know because this is my goddaughter. I have treated her whole life. I know exactly what she felt like before she had braces. So one night I was reading my Victorian murder mystery. I got a call from her parents that she was suicidal, wanted to know what to do. Did they need to take her to the hospital and put her on a psychiatric involuntary hold? Because they said it'll traumatize her, but if we have to do it, we'll do it. You decide. And I thought about it. It's like, what are they going to do at the hospital? They're going to give her Ativan. I can give her Ativan. I went in to the 24-hour pharmacy, went over there, put my hands on her head, and she was torqued. She was torqued in 3 different dimensions and locked down, and nothing in that system was moving. And I know that none of that was there 6 months earlier because I've treated her. I called in a favor from one of the dentists I work with. We took her over the next day. He took the power chain off her braces. I could feel it. She could feel it. And her mother could actually see the untwist in her face. So, some cases of iatrogenic harm from oral appliances. And like I said, this one, I use this a lot because I do know exactly what was there before. And I know that it kind of came from the braces. All right, airway. You guys do a lot of airway. I brought this up in the osteopathic principles. I want to introduce this concept to think about airway is function more than structure, more than a structure.
Dr. Hulse,
Yeah.
there's a question that popped up in the chat.
Yeah.
2 questions, and I'm wondering if maybe we could go ahead and ask them now because they may.
Sure.
Okay. How can we prevent compromise in these systems before kids or even adults are placed in orthodontics or growth expansion appliances?
How do you prevent the well, I think the question really is how do you evaluate the compromise? And so some of it's hard. I will say the dentists that I work with have all now gotten to the point where before they put anything in, if there's any question in their mind, before they put anything in, they say, go see Dr. Hulse, and then she'll tell you when you can come back. And so a lot of it is I treat it out first, or at least I identify it first. In terms of preventing it, to keep your eyes open for when there's structural anomalies, when you see something that's structurally a little odd, and I don't mean genetically odd, I mean just a little more compromised than usual, there's always a reason, right? There's some underlying reason that child developed that way. And then you can also things like, so kids I treat a lot of kids on the spectrum. So ADHD, food allergies or food sensitivities, celiac disease or non-celiac gluten sensitivity, things like that that are going in. And this is where I go back to the medical piece of when there's medical and something. I mean, that's alternative medicine, medical sometimes. But those are other ones just to be aware of and be careful of. And the last one would be kids or adults for that matter. One of the dentists I work with uses the term, they're a delicate flower. Anybody who walks into your office and they feel delicate, that's another one. Whereas there's the kid who comes in who, is just exuding energy. Even if there's compromise in that system, they probably have the resilience to deal with things. So I don't know if that answers your question, but that.
Yeah, I think so. If Anne, if you want to respond to that in the chat, you're welcome to. She has a second question to this.
Okay.
Anne does say, she says it does. Thank you.
Okay.
The second question is, do we know the amount of force the cranium can take before decompression ensues?
Less. I'm going to talk a little bit about that, and when I just in my little piece on the ALF, so I'll talk about it.
Perfect.
And if I remind me. So the second takeaway, I want to just introduce this concept that airway is as much a function as it is a structure. So this is the single biggest airway of any of the patients that I have imaging on that I see. It has a minimum, she has a minimum inspiratory area, I think of something like 400 and some odd square millimeters. This is the smallest airway in my practice. Her minimum inspiratory area is 46 millimeters. This patient has sleep apnea. This patient does not. And I know she does not. Everybody thinks she should. She's had so many sleep tests because they look at these images and go, oh my God, you must have a terrible sleep. So airway is not just, it's not just what we see on image. And I want to, for all the myofunctional therapists in the group, you probably know, but if you don't, you should have this literature reference. So this is a systematic review and meta-analysis that was published in the journal Sleep in 2015. And what it showed was that myofunctional therapy, on average, decreases the AHI, the apnea-hypopnea index in sleep apnea, by 50% in adults and by 62% in children. Now that's myofunctional therapy by itself. No surgeries, no appliances, no RPEs, no tonsillectomies, just the myofunctional therapy. Which goes back to this concept that airway is not just structure, airway is function. And so that's the second takeaway that I would want to leave you guys with. It's not that they're correlated, for sure, they're correlated. And this is why everybody who comes to my office with sleep apnea, I want to get into myofunctional therapy. Now, they can't all do it. Kids can't do it. Kids on the spectrum a lot of times can't do it. Adults don't necessarily want to do it, but if they're interested in staying out of CPAP, this is where we always start. All right, so this is taken directly from Dr. Nordstrom. When he developed the ALF, he very specifically developed it as a team approach between dentistry, the dental appliances, myofunctional therapy, and osteopathy. He studied with several of the osteopathic masters. And when we go back to the things that I talked about before, the dentist is really working on the structure. The myofunctional therapy is working on the function of the tongue, which may not be, and the breathing, may not be the only function involved. But those are clearly big ones. And then my job as an osteopath is really that integration and putting it together and finding those, anything that's going to get in the way of treating the structure and the function. So this goes back to how do you know about the compressions, and why the dentists send me the people in the first place is I find those things early in the process and treat them out so that then the dentist, the appliance, and the myofunctional therapist can do the work that they need to do, and it can go on unimpeded. I will tell you that every single case that I've seen, I mean, they didn't see me, but that I'm aware of, where ALF, quote, failed, is because they didn't get the osteopathic treatment they needed. And that's the other reason that the dentists always send them to me first, is because they don't want to deal with failure. They don't want to deal, everybody gets frustrated when things are not progressing. Now, this is, as I said, this was Dr. Nordstrom's, but it's not just ALF. This applies to any kind of dental appliance that you're working with to think about the pieces of the structure, the function, and the integration. And people enter this triad at any point, and particularly people who will come into myofunctional therapy with different appliances or having been referred by different dentists. And I'll see a number of them because the myofunctional therapists that I work with know enough to say, yeah, there's something going on here. Even if they're in a different appliance, doesn't matter. We need to deal with the underlying structural, the compressions and the dysfunctions and the distortions and what we call the cranial strains in order for this patient to really thrive. So with a dental appliance of any kind, this is what I'm looking for, that it not interfere with normal function. And with normal function here, I'm not really just talking about the tongue and the breath. I'm talking about the movement of the cranium. That it supported normal function is even better. And if it enhances it, it's the best. But sometimes you're not going to get that. And because the system won't do it, or no appliance is perfect. But as long as it doesn't interfere with normal function, I'm happy. And so people come in all kinds of appliances. And if that appliance fits that patient and it doesn't interfere, great. So that's always the question. One thing I will say is, with a lot of appliances, is the appliance works if the patient fits the appliance. The difference with the ALF is the ALF is highly customizable, and so you can make the appliance fit the patient. That's most important with these people who are compromised or who are delicate. But even then, there may be appliances that fit them. It's just hard. It's hard to know up front. I can't even tell up front. Although I can give you give you some guesses if I feel them, but looking at them, I wouldn't know how to tell you this person is good for that appliance. I'm going to skip through that for a second. Okay, so this is Dr. Nordstrom. I'm going to talk a little bit about the ALF. So one of the concepts of the ALF is that when you give a stimulation at a very, very low level of force, the body will respond to it. Whereas if it's a higher level of force, you inhibit. And sometimes I do this with patients. I had a new patient in yesterday, I was doing this, is that we walk shoulder to shoulder. And if I just ever so slightly lean as we're walking, I can move them 90 degrees. But if I push, they push back. And that same thing is true in the body. So that the ALF has this very, very low level of force. It's why it needs osteopathy, because it's not going to blow through a compression or a strain pattern or a piece of that sutural interaction that's locked up. It's not going to force it open. But what you can do is you can nudge it open. You can nudge it open in a way that when you put a lot of force in it, you actually just jam it more together. And I've seen that many, 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 many times. So I don't know if that exactly answers that question about how much force can you put in. But my basic answer is if you're putting in a lot of force and you're not getting anything, that's opposed to you need more, that really it's you need less. Now you might need less and some other help, which may be osteopathy, it may be myofunctional therapy, it may be buteyko breathing, it may be something else. But I also want to be very clear about my biases. I see the train wrecks, right? But I have seen so much harm done with too much force. And often that's immediate. Some of those cases that I gave you earlier are immediate. But a lot of them are later down the line. I'll see them 5 or 10 or 20 years later because they were healthy and robust when it first happened. But then something else compromised their system and they couldn't deal with the optimal outcome later. All right, so view of the ALF is not just the teeth and not just the airway, but really looking at the whole person. And as the osteopath, that's my job. But even the dentists who work in that realm will start to get a feel for this is, oh yeah, this is cervical. This is not in the mouth. This is coming from posture, or this is coming from the sacrum or something like that. So the advantages of the ALF are it adapts to fit the patient. It's a custom design, and the adjustments are always custom too. It stimulates natural growth and development. And yes, even in adults, you can get a lot of palatal adjustment in adults, even though I've also heard people say that's impossible. And it's really, you're not going to do harm. It's very hard to do harm. Now, those are the advantages. Those are also some of the disadvantages. Because it's adaptable to fit the patient, it requires a lot of expertise from a dentist, particularly with complicated patients. And in some cases, at least the patients I work on, the dentist probably can't get there by themselves without osteopathic help. I actually go into the office of some of the dentists I work with, and we do these things together with direct feedback, boom, 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 with these really complicated people. It's expensive. It's expensive for patients. It's also not a great moneymaker for dentists. I'm sure that they could do well on it, but it's not one of these big, oh, here, come take a weekend course and you can make all this money. I tell patients that. I figure I can because I don't have anything to do with it. The dentists who do this do it because they want to do the right thing. They're committed to health. They're committed to doing the best thing for their patients, not because they're making a lot of money. Even though it is expensive, it's not a big money maker. It can be slow. Now, that's the flip side of not putting a lot of courses in it. It takes a little longer sometimes. It doesn't always take longer, but sometimes it does, particularly with complicated people, and particularly with adults. Adults, you don't get to ride the growth waves on them. So it does take a lot longer. And it often requires, again, with these complicated people, additional therapies, myofunctional therapy, osteopathy, maybe some other things. And so this goes back to the expensive part. Not only is the dental part expensive, but all the adjunctive treatment is expensive, yet necessary to get the right result. So I don't know if you've seen ALFs before. This is an ALF. This is a basic ALF. There's a whole family of appliances. These are what are called omega loops. And what the omega loops do is they provide this expansive force, not just AP, anterior posterior, and not just transverse, but in a radial, or what we used to call, when I was an engineer, we called hoop stress. So it's a radial expansion all the way through, which is a very different, it ends up having a very different effect. And it's a really light wire. So this is so you can see. I'll play it one more time. This is not putting lots of force in. This is nudging that expansion. You can get a lot of expansion. If I have removed all of the restrictions, you can get a lot of expansion relatively quickly in a healthy, robust kid, but it's not with force. It's with nudging. And that's what it looks like in. As I said, there's a family. So a lower one's this is an upper. A lower can look exactly the same, but there's also versions that add some vertical height and disclusion. Vertical height is really important in, well, cases that I deal with a lot, but particularly autistic kids on the spectrum. Sometimes there's a labial wire. Those are just some examples of what they kind of look like. And as I said, this team approach can be used regardless of what dental appliance you're using. The team approach and the concept, the conceptualization of how we work like this. So when do you need help from somebody like me? Well, I would say when your case is going south, when things are not progressing according to plan. These are, I know the question that was, how do you prevent it up front, and which is a lot harder. But I see it when it's happening in real time before you've gone too far off course. That when things are not going the way you think they should, and this is true in myofunctional therapy as well as with appliances, when somebody is doing their exercises and doesn't seem to be getting the results that you expect, or when a kid just hates doing the exercises, sometimes that's not because they're non-compliant or difficult, sometimes because it doesn't feel good, because there's something in that system that's hung up. And I have seen kids, I actually have seen the opposite. I've seen people who are so compliant and they do their exercises and it does them harm. It really disrupts their system because it's not good for them. It's too much, or that the tongue is such a strong muscle, it can really pull on things, much less than if you're working on the bones, but it's still true. So case is going south, it's not progressing according to plan. And here's this: when the patient is delicate or compromised or medically complicated is another time when it's really good to call in an osteopath. Again, that medical complication would be, depending on how complicated they are, that acting more as the physician input into that. How do you find one? Well, one option, as Angela said, I'm the immediate past president of the Cranial Academy. And so the Cranial Academy does have a find a physician function on their website. I went and looked. Again, this sort of what prompted my question: where is Central Virginia exactly? But I will tell you, there's 2 colleges of osteopathic medicine in Virginia, one in Lynchburg and one in Blacksburg. So there are OMM faculty associated with both of those. I believe the one in Lynchburg also has a residency associated with it. There are also, there's a Jim Bronson's an ALF dentist who works in Charlottesville. So there is a DO and an MD who are both osteopaths who work in Charlottesville and have seen a lot of his patients. And then one other one, which I put on there, I'm mostly talking about osteopathy. This is a massage therapist who has done a lot of craniosacral therapy. She's actually an old friend of mine. She was on the Upledger Institute faculty for many, many years. Because she's in Charlottesville, she was seeing a lot of Bronson's patients, and knowing nothing about my relationship with that, called me several years ago and said, have you ever heard of this ALF thing? So she's somebody that I happen to know has done a lot of extra training and I would be, happy to send most patients to her. Maybe not the most complicated ones or the medically complicated ones, but if you need a craniosacral therapist she's probably as good as they get in that way. So I want to go back to ARC can come in from many tools. ALF is one. I would never say it's the only one. I talked a little bit about the advantages and disadvantages. I'd say this is not a chainsaw, is not how I would choose to make art, and yet people do. So I think the important and the take home there is it's being aware of these issues that I've talked about, the things that can happen in the head when you blindly put in forces and working not to do that. And even if you're working with a high force appliance, if you're aware of the things you can do and you can avoid harm, you can do your patients a lot of good. And my job is to till the field. All right, so I'm going to stop my screen share, and then I think there's some questions in the chat.
There are, yes. Oh, that was wonderful. I took a bunch of notes here. Thank you, Dr. Hulse. That was great. That was wonderful. Virginia is clapping her hands right now. And we do have a lot. I have several of my clients. I have a whole family, 3 sons and the mother are in the ALF Appliance with Dr. Bronson up in Northern Virginia. And I'm just about an hour and a half from Charlottesville. And I'll be headed that way a lot, Renata, because my son is now going to be attending the University of Virginia. So anyhow, let's go ahead and get to these questions. Let's see here. I'm going to scroll back. Wow, these just so awesome. As myofunctional therapists, are there any specific things we should look for in our assessment and then even to warrant a referral to a DO?
Yeah, that's a hard one because for me, it's all about the feel. Let me give you an example. It's not specifically on point, but I'm going to give you an example of a lot of people get referred for frenectomy. And the myofunctional therapist assess them by looking at their frenulum and go, oh yeah, that's. But when they come to me, what I do is what I want to know is what they feel like. And what I'm specifically looking for is if the frenulum is what's keeping the tongue from getting to the top of the mouth, then it will be tight. And by that, I mean the submandibular muscles. There will be tension. If this is the tether, it's going to be pulling through here. And I get a lot of people who have been referred for frenectomy by my functional therapist because it looks tight, and I assess them here and it's fine. Which means that this is not what's holding it. I mean, the frenulum may be tight, maybe eventually it'll get there where that's the critical path. But if this is all nice and loose, the frenulum is not what's keeping the tongue up. It's a functional problem, not a structural problem. And I go back to function beats structure. So what should you guys look for? Probably the bigger one is how well they can do the things you ask them to do. It's going to be, can they do the exercises? Can they do them with a little bit of practice, or is there something that just doesn't work? Do they complain of worsening headaches or worsening TMJ pain? Or this depends on the kid a little bit, right? But one of the things, I haven't seen this as much, but one of the dentists I work with has learned is one of the things the tongue sometimes does is the tongue will support the cranial mechanism. And if you train the tongue to not support the cranial mechanism, then the whole thing goes haywire. That's what I was talking about, those compliant patients who can do themselves harm. And so to really be be aware as you're going through, if you start to see signs of things going south, even very early, to know that there's something else going on there that you may not be aware of. Now, the other thing you can do, and this for any myofunctional therapist or dentist, well, for the myofunctional therapist, you can go take classes from the Upledger Institute in craniosacral therapy and learn to feel the mechanism yourself. For the dentists, now dentists can actually come to our courses. The Cranial Academy has intro courses, Introduction to Osteopathy in the Cranial Field, for DOs, MDs, and dentists. So dentists can learn it with us, but any myofunctional therapist can go learn it through the Upledger Institute. And so that's another one. You can put that in your toolbox of, can you start to feel how things move? And then you can feel for yourself. It's like, oh yeah, no, that's not good. You may or may not be able to treat it. If it's simple, you might be able to treat it if you studied enough. But even if you don't treat it, to be able to diagnose it, or at least have a yield sign come up. So that.
Thank you. That's pretty spectacular. And I wrote that down too. And I'm thinking, who wants to go on a road trip with me? I think we should all sign up for this. Oh, okay. Real quick. What courses can nurses or BSA take?
Nurses can also take the craniosacral, the Upledger Institute teaches craniosacral therapy. So the craniosacral therapy is just a highly simplified form of cranial osteopathy. John Upledger was a faculty member at one of the osteopathic colleges. He got pissed off because he didn't get a promotion. And because he wanted, so he said, screw you guys, I'm leaving. And he started teaching massage therapists the basics of what he wanted to do for his research. That's really what, so nurses, physical therapists, massage therapists, all those people can learn through the Upledger Institute.
Okay, wonderful. We have another question. Is the wire nickel titanium?
The wire, there are different wires. And now you're in an area where I don't really know all the specifics. I will tell you, I have had patients with Dr. Nordstrom who are super, super sensitive. And he would test different metals actually before making their appliance. There were some that, and again, I don't, we're out of the, but I know, I think it was some, is it nickel that was a problem or aluminum that was a problem? I forget. That where people, but the point was the alloys he was using were very, very inert. So that even though they may contain something, people who were super, super sensitive could still tolerate them. So I'm sorry, I can't give you any more specifics than that.
No, that's great. I don't want to interrupt. Doris, go ahead.
The reason I asked that question is because when he was bending it, it had real spring in it, and nickel titanium is very springy, and you can bend it to whatever, like you can bend it this much or this much, and it'll still apply the same amount of force to the teeth. That's what made me ask about the nickel titanium.
Yeah, I don't know.
You don't know. Okay, that's fine. That's fine. I worked in an ortho office, so I wanted to know if osteopathy would help a child who has a really sensitive gag reflex, a 4-year-old.
Yes, I see
Yes?
that. Yes. The simple answer is yes. And because it comes from, I'll tell you, I treat this a lot. It comes from a couple places. It's often related to compression through the occipital,
Yep.
Where the hypoglossal nerve comes through. The other place that it can
Yep.
be related is when in the birth process, the cranial bones have to overlap each other for the baby to
Yep.
get through the birth canal.
Yep.
And what I've seen in I treated a lot of babies with nursing problems, that the 4 bones of the palate, the 2 maxilla and the 2 palatines, after they've done that overlap, don't pop quite in alignment.
Okay.
And so sometimes treating the palate actually can help with the gag reflex too.
Okay. Thank you so much.
Wonderful. Thanks, Doris. I'm really glad that you took your mic off of mute. And anybody else, of course, is always welcome. That's why we keep this an open forum and an open room. So not only can you just send us your questions, but you can also unmute yourself and speak. Do you see a lot of autoimmune compromise in the cohort of medically complex patients you work with? Sorry for stumbling over that.
No, that's okay. Yes, I see a lot of autoimmune patients. Another group that I work with a lot is patients with autoimmune diseases and with Lyme. So there's a couple functional medicine doctors who refer to me. And those patients are often not in dental appliances. They have other issues. They're more chronic pain. I'm trying to think. I do have any of them? I mean, I'm sure I have a few that are in ALF or other dental appliances, but that's more of my chronic pain patient population. So you can imagine rheumatoid arthritis, ankylosing spondylitis, those kinds of autoimmune diseases have a lot of chronic pain associated with them.
Yeah. Yeah, thank you. How often do you see patients in active ortho, and what factors determine whether the treatment sticks?
So that it's highly variable. And so when I get somebody, and I'll use, just because I see more ALF, I'll use that as my template, is the dentist sends them to me and says, tell them when to come back. So I assess, find out what kind of compromise is in structural compromises in that system, the cranium. If it's fine, I'll treat it once or twice and say, go back, come to me when you get your ALF, and we'll check it again because we've now put a little bit of force in. And if it's fine, I'll say, come back after a couple adjustments. We'll check it a few times. If it's a lot more, there's a lot more strain in that system. Sometimes I'll see them 3 or 4 times before I send them back to the dentist and say, now the alcohol. For me, I can treat a system that has a lot of cranial strain. I would have to treat probably 10 times more if they didn't have an ALF, because the ALF gives me that expansion, and then I can untwist and unwind as the expansion comes through. So a complicated one, a kid, I will often see every month for the first 6 months. They usually get their ALF adjusted every month, or every 6 weeks. I'll see them every 6 weeks for the first 6 months, and then I can usually skip. It'll be every 3 months, and then 4 months, and then 6 months. A less complicated kid, I may only see 3 or 4 times, but it depends. I had a couple kids in the last few months where they came in and I'm like, go see the myofunctional therapist. What you need is myofunctional therapy. Don't spend your money on me. So I'm always gauging that what's me versus myofunctional therapy versus the dentist.
That's great. Yeah, I love it. The next 2 questions, I'm actually going to combine them.
Okay.
And it really just comes down to, how do you test? So how can you test for metals? And then you also mentioned that you treat patients with food allergies. So how does that work?
So most of the time I'm not doing that testing. So there's something called functional medicine. They'll do the testing for metal sensitivities, for food sensitivities. There's also when Dr. Nordstrom was testing metals, that we were doing he was doing with muscle testing. So, but I'm not doing most of that. I mean, I will do a little bit of muscle testing. I'll take it with a grain of salt. It's information, right?
I do have a closing question. And then we're going to turn this over to Renata. And, of course, Annette, let you have the last word, but have you ever bitten off more than you can chew in treating a patient?
I have to say, I've never thought of it that way. I have a lot of patients who, and this is something that I deal with. I have a lot of patients who are chronically ill and they're not going to get better. I can help them maintain, but they're not going to, so I have patients. I had a patient a couple months ago, she had cancer and passed away. I can't, as a doctor, I have to deal with the fact that I'm limited in what I can do. So have I had patients where I do everything I can? That basically is what I do everything I can. I will often come up with what I'm doing isn't helping you. Let's try. I try to direct them. Acupuncture, ALF, functional medicine, food testing, whatever it is. But in terms of bitten off more than I can chew, like I said, but I recognize my own limits. I recognize my limits, not only at the beginning, but all the way through the treatment process. I can work in a box, and I will work outside of the box, but there is a limit, whatever that is.
Yeah, you do what you can and do no harm, and just do what you can to help. That's right.
Yeah.
I do see some movement on Renata's screen.
Yes, I'm
and-
here. I'm here.
Oh,
I just
you
have
are.
to get up because he's ready for bed.
Oh, okay.
Dr. Holst, thank you so much. This has been a wonderful presentation. I know you guys cannot see me. Benny won't let me sit down. But I did have a question. Okay, we're going. It's a couple different questions. Let me know if you guys can still hear me.
I can hear you.
Okay, one person, Kendra asked, I missed the name of the institute. She wants to know how to get trained. And then my question is, if you do not have a cranial osteopath around you and you're doing the alpha myofunctional therapy, what are some other options? Thank you.
So, okay, so the first answer is the UpLedger. It's UpLedger, the UpLedger Institute, trains craniosacral therapists. If you don't have a cranial osteopath around, my first choice is a cranial sacral therapist. Now they're very gentle. They're trained in some of the treatment modalities. They don't know how to diagnose for the most part. And so if the treatment can work, if they don't know, I don't want to say they don't know what they're doing because that's not exactly right, but they're going to treat, but they're not going to be able to say why it didn't work. So that's your best choice, and the more experience they have, the better. And that's why I gave you guys the name of Judith Sullivan, because she's very experienced and has a lot more knowledge than the average craniosacral therapist. Maybe you could get her to teach you things.
I think that would be great. That would be wonderful to have her. Okay. I want to be very respectful of your time. I know how I know that you're on the West Coast and we're on the East Coast here. And just to be respectful of your time, we really, really are thrilled that you came on and you joined us tonight. And we are just so, I want to keep going. I don't want to I don't want to end this. But
I'll talk about next week.
Okay, perfect. Thanks. Yep.
All right. So next week, I want to invite everybody to come on Thursday night at 8 p.m., our same time every week, to come listen to Lisa Palladino. She is the host of Tongue Tie Experts podcast that I just did this week. She'll be coming out in a couple of weeks, so super excited. And she's going to be talking about breastfeeding and airway health. So I cannot wait to see everybody there. We also have a tension and movement course that we're doing with Elizabeth Morel. Supposed to be on the 23rd of August. I'll keep you guys updated with that as soon as we have everything finalized. And also we are starting our lung myo course on Monday. So if you're a dental hygienist who still have not taken the leap into having your own practice or just being confident to just get out there and start seeing tons of patients, we are here to help you. You still have a little bit more time to join us. So thank you everybody so much for joining us tonight. Dr. Annette, you have been wonderful. I really, really appreciate you teaching us so much.
All right, it's a pleasure to be here. Nice to see you all.
Thank you. Thank you.
Annette, do you have any
Thank you,
closing
Angela.
words? Dr. Hulse? Yes, do you have any closing words for us?
I don't have anything. I didn't say, I think it was on the very first slide and I didn't call attention to it, but feel free to shoot me an email. If you have questions, I can try to direct you to a local osteopath, or if you want to know, whatever. My email is Dr. Annette Hulse, DrAnnettehulse @gmail.
Awesome. Thank you so much. Oh, this is wonderful. Everyone, thank you so much for joining us tonight. And Renata's going to go ahead and end this session. So Dr. Hulse, thanks again. And everyone else, have a great night.